So welcome back to my lecture series. I noticed it's been 10 months since my last recording, so hopefully this will be a more regular thing from now on. So today's topic will be trigeminal neuralgia. So what is it? So it's considered part of the neurovascular compression syndromes. It's described as this very sharp electric shock, like pain that's in the distribution of the trigeminal nerve. So in the diagram here, we've got the V1, V2, and V3 that's represented by the different branches of the trigeminal nerve. And it affects this region. It's often quite triggered by sensory stimuli, sometimes even just lightly touching the skin. Patients describe eating and opening their mouth as triggering for the pain as well. And interestingly, neurological exam should always be intact, and there may be some mild sensory loss in the pattern of where the pain is. It's found that large proportion of these cases is because the nerve is being compressed at the root entry zone by the superior cerebellar artery. So a particular vascular structure, usually the superior cerebellar artery, is just adjacent or compressing the nerve, causing this pain. In patients with multiple sclerosis, it's just due to demyelinating plaque that can cause this issue. It's noted that about 75 of patients will probably fail the medication therapy and will ultimately require a form of an operation. And the incidence of this condition is actually quite uncommon, about 4 in 100,000 patients. So I guess how it works, it's an emphatic transmission of the trigeminal nerve from these large diameter, partially demyelinating fibers to the thin myelinated fibers. And the causes, as we talked about, most commonly, it's that superior cerebellar artery. They quote around 80%. Then there is about the other two sort of broken down into a persistent primitive trigeminal artery or the abnormal basilar artery as well. More uncommonly, posterior fossa tumors that could be pressing on the nerve itself, and multiple sclerosis. And we know that if there is multiple sclerosis plaque that causes this condition, it's often really poorly responsive to some of our microvascular decompressive surgeries. Now, in terms of usually before I go through the distribution of where it usually involves, a large majority involves V2 and V3, so just less than half, when the second most common is this V2 region as well. Now, in terms of how we evaluate and diagnose this condition, history is very important. So just getting a very good description of where the pain is and where it's localizing to. Trying to also understand the timing of when it happens, anything that triggers it, determining how long, if they have any pain-free intervals, is quite important as well. Um, And if a patient's saying that they're not having any pain-free intervals, it's actually quite atypical for this condition. Then trying to see what medications they've tried, what doses, how long they've been on it for, if there's any other associated symptoms that could point us towards another condition, like any vesicles, any tongue pain that could indicate glossopharyngeal neuralgia, facial twitching like tics, any sensory loss or progressive, relentless pain. We can think about tumors as well. The physical exam is usually quite normal, apart from the mild sensory loss that we talked about before. Now, imaging. So MRI is our ideal mode of imaging. It helps identify if there's any sort of vascular structures. Plaques, it can also be identified for multiple sclerosis. So I guess in this image here, you can see that there is the trigeminal nerve, and it's being compressed by the superior cerebellar artery above. So, a role for microvascular decompression of this nerve could be indicated. Some particular protocols that are important in terms of imaging is the Fiesta protocol that can help delineate these structures better. Now, medications, usually things like carbamazepine is the first go-to. It has a good response in around 70%. There are other forms that can break down into carbamazepine. Baclofen is not as effective, but it's been told that has less side effects. Gabapentin can work together with some of the above medications. Things I've probably not really seen as much as phenytoin, clonazepam, lamotrigine, some of the anti-seizure medications, amitriptyline, some other nerve-related medications, Botox injections, and intranasal lidocaine spray has also been documented to say that they may have some temporizing relief as well. Now, in terms of surgery, I guess things why a patient would be considered for surgery would be if they are refractory to medication, or if the side effects of the medication sort of exceed the potential risks of surgery itself. And there are different forms. So there are actually more than these two options that I've listed here, but these two are the most commonly encountered ones. So that's the ones I'll probably be going through today. So percutaneous trigeminal rhizotomy is it's more of a percutaneous, so going through the skin to trying to get close to the trigeminal ganglion, and then through different forms, either through radio frequency currents, injection of something called glycerol, or even inflating a balloon to compress the nerve. It can help treat this condition. They generally reserve for people that have probably poor risk factors for general anesthetic. They want to avoid a major operation. They've got like a large tumor that's very high risk for removing, multiple sclerosis, or limited life expectancy. And those are the three options that we just talked about. Then microvascular decompression, usually they need about more than 5 years of survival, intractable pain. But multiple sclerosis doesn't tend to respond very well, but again, can be considered, especially if there is a form of vascular compression, but it really has to be on a case-by-case basis. So I guess how they perform it, using one hand to palpate the buccal mucosa, being very careful to not unsterilize the field with the other hand. You insert the needle sort of medial to the coronoid process of the mandible. And then you try to aim for where the plane intersects, so 3 centimeters anterior to the external acoustic meatus and the medial aspect of the pupil. So you're aiming towards that, and you're using fluoroscopy as well. And once you get to the intersection of the petrous and the clivus, about 5 to 10 millimeters before the floor of the cella, you can then, upon entering the foramen ovale, they mentioned that the masseter muscle often contracts. You can remove the stylet and then observe for CSF. Often they say that if they have recurrent rhizotomies or percutaneous rhizotomies, the CSF may not come out. But yeah. And then finally, microvascular decompression. I'll sort of go through. This is a very simplified method of sort of the steps of what the surgery will involve, but generally it involves a skin incision, usually quite vertical, and you can see that it's about 75% inferior to the transverse sinus over here, about 25% superior. You make a burr hole 1 centimeter inferior and medial to the astrion, and you do a craniotomy. The dura can be opened with a curvilinear incision, or also they've mentioned that it can be an inverted T incision, usually with one incision towards each sinus and a third towards the junction of the sinus. It just helps you get as close as possible to the sinuses. Usually at this stage, minimal retraction of the cerebellum is required, and you try to allow all the CSF to drain Um, and a lumbar drain can be considered at this point if the CSF is unable to be drained. Then the next step is really just to lift the cerebellum slightly and just follow the junction of the tentorium with the temporal bone quite deep. And I guess they also mentioned that the superior petrosal nerve, petrosal vein drains to the superior petrosal sinus, and they may actually block access to the fifth cranial nerve. Coagulating and dividing this can be quite controversial, actually, um, because you're risking cerebral infarction, midbrain and pontine infarction, so you really want to avoid that as much as possible. And then now, sort of getting to the decompression of the nerve, you're sharply dividing the arachnoid layer that's overlying the fifth nerve. It can be noted that the fifth nerve can be quite atrophic, especially if percutaneous therapies have been done before. And then really dissecting off any of the arteries or veins that are compressing the fifth nerve. And then to actually decompress the nerve, they use an insulating material. There are different types. The ones I've commonly seen is Teflon, and that's used to really pad in between to help avoid it compressing. And now, in terms of the closure, bone wax should be applied quite liberally. You irrigating it with warm saline, watertight closure of the dura, and then it's sort of standard from any sort of craniotomy. You're covering the bony defect, fascial and skin closure. So that sort of summarizes what trigeminal neuralgia involves. It's a very simplified, and of course, this information shouldn't be used for sort of actual clinical practice, just more for education. But yeah, thanks for listening. Hopefully, there'll be more in the future. Um, Comment down if you think that there's any topics that would spark interest or be helpful. All right, stay tuned.